things that are important for our specialty. We will discuss about the association of traumatic injuries, the more anatomic regions or organs, and separately or in combination life-threatening in polytrauma patients. In most cases, the most common mechanism from polytrauma patient is represented by the road accidents. We have a high percentage for that type of mechanism. Other mechanisms are represented by work accidents, falls from high, and suicide attempts. We have a patient with a big injury trauma, and it is very important to establish the diagnosis and the correct treatment that we have to make for a good opportunity for that patients. Okay, we are discussing about the life-threatening. It is very important to put the correct diagnosis. It doesn't have just one diagnosis of fracture, for example. It is a complex case, and you have to treat with responsibility. That injury and site and frequency that could appear in that patients, cervical spine trauma in half of cases. Most important is the chest trauma that could lead to half of that cases, abdomen trauma, spine, and we discuss in that type of lumbar fractures, and pelvis and extremities are very, very, very frequent, and it is very important to put the correct diagnosis and to establish that that patient has just a pelvic trauma or has an association with pelvis fracture or extremities, lower limb or upper limb fractures, and a trauma to the abdomen, chest, or other sites. It is very important because the prognosis is different, and our treatment it has to be from all the trauma. The mechanism of lesions in most frequent cases of polytrauma or polyfracturated patients is with direct impact. Indirect impact, it is not very frequent for polytrauma patients. If we are discussing about an indirect impact, it is the hyperflexion or hyperextension or a big contraction. For example, a big contraction of the triceps could lead to a fracture to the olecranon, but that's a not direct impact. And in most cases of polytrauma patients, we have high energy impact with a direct impact. You have to make a difference between the syncope and the coma. It is very important to know what is syncope and what is coma. We have a scale for coma, and we will discuss later about that important type of classifications of coma. In syncope, we have a temporary loss of consciousness, and it is reversible. It is very important to make the difference between the syncope, because in coma has varying degrees, and we will discuss about it. It is very important to put the diagnosis of hypoxia, of respiratory distress, on argentine evolution, because in most cases the coma patients have a big problem with cranial or cerebral injuries. If we are discussing about the thoracal lesions, are the lesions of the upper airway, the trachea, the lungs, the chest wall, or in case of hypoxemia, could be in the patients with the diaphragm injuries. And it is very important to put the diagnosis, because if you are not, you can lose the patient. The cardiopericardial injury, we have here the pericardium or cardiac tamponade, and it is very important to establish that kind of lesion because it is very important for our evolutions of the patients. In the abdominal injuries, you can discuss here about the digestive tract, hollow organs, septic shock in 12 hours maybe. That's complication that could appear in hollow organs or parenchymal organs. We have here the most common complication is the hemorrhagic shock, and it is very important to check for the hemorrhagic shock because in fracture we are losing about 2 to 4 liters of blood in a femur fracture, for example, and it is very important to determine what type of hemorrhagic we have because could appear that hemorrhagic shock in association with the parenchymal organs. In the case of injury of limbs, it is the most frequent association for polytrauma patients. We want to establish if we have a soft tissue injury, a big soft tissue injury, because could appear the crush syndrome that appear in muscles lesions, in big muscle lesions, and due to rhabdomyolysis that could appear the acute kidney failure, and it is very important to put the diagnosis very quick for that type of patients. Other kind of complications could appear in open fracture. We have a classification that we are using for that open fracture. The name of classification is Gustillo-Anderson, and it is a very good classification because by typing Anderson classifications, and that classification establish the kind of treatment that we have to apply for a good evolution. For the the patients could have an abnormal evolution. It's very important to know how to treat that kind of emergency and what do you have to do to have a good evolution in that cases. There exists some Gustillo-Anderson type 3C, and we have a big complication with the vessels and with the nerves. In that kind of patient, it is very important to remake the vessels and to permealize the tissue, because otherwise it will be a catastrophic evolution. What have we to do in the patients that have a big trauma of upper or lower limb? It is very important to take the segment, otherwise it's a knee, it's about the ankle, doesn't matter. It is you have to put that segment in a cloth, and it is very important not to put ice on the segment, not to touch the ice with the segment. That it is very important. The time between that segment is amputated and the time we intervene in our hospital, in our clinic. we have three objectives to determine the severity, the shock, the anemia, the respiratory disease. You have to complete the lesions investigations. Angiography, it is very important to make in the patients that you think that could appear that kind of complication, and to establish the hierarchy of injuries and to make a very good treatment. The hemorrhage, it is very important in pelvic fracture, and you have to check always for the hemorrhagic shock. In our pelvic fractures, we have blood loss 4 to 5 liters. In femoral fractures, we have 2 to 3 liters of blood. In tibial fractures, could be 1-2 liters of blood, and in humerus fractures 1 liter. It is very important to make a cardiopulmonary resuscitation protocol in a polytrauma with vital functions affected. We have the ABC for life support. It is very important for all of you to know the ABC that we have to make in that patients. There exist some scores for coma. The name of that score is Glasgow score. We don't use frequent that score. We are using the ICC score, the injury severity score. Why? Because in that score, it included the limbs trauma and the skin lesions. It is very important. You have a trauma on the chest or on the head, but it is very important to put the diagnosis for the limbs injury, the skin lesion, the soft tissue, the muscles lesions, because as you can see, it is a very important component of hemorrhagic, of blood loss in that kind of lesions. And we are using that ICC score, injury severity score, for to make a correct and complete diagnosis in that patients. If we are talking about the cardiopulmonary resuscitation, it is very important to know that ABC for resuscitations, and we can see in that picture the stern, the point that we have to put our hands to make the cardiopulmonary resuscitations. It is about from 2 centimeters proximal than the median line. You have to put your hands. It is very important your position. As you see in that image, you can see that our elbow is in extension, because we have big forces to make the cardiopulmonary resuscitation in that position. It is very important to check the airways and to put the head and the neck in the correct position. We have to put in a hyperextension, and we have to listen and to feel the breath of the patient. If we have to make that kind of maneuvers, you have to put a finger on the mandible of the patient to make the hyperextension from the neck, and with the other hand you have to use on the nose of the patient, because otherwise your oxygen, it will be lost on the patient nose. And it is very important to put your hand and to make that maneuver. For the babies, we will not discuss the cardiopulmonary resuscitation, because we will discuss in other modules. Okay, that's an example for basic life support that was made on the accident side. And then the advanced life support, that's a type 3 of Gustilo-Anderson open fracture, and we have a complete rupture of the tibial artery, and it is very important to make a correct diagnosis, to put a correct diagnosis and to make correct maneuvers for the hemorrhagic shock. We are doing that very quickly. It is very important to make very quickly because of the blood loss, and you have to put an external fixation. It is a different treatment between the normal, the closed fracture, to an open fracture. Important not to colonize the fracture with that germs. We are doing that by putting an external fixation with some special wires that we are introducing. The wires are not introducing in the fracture side. It is in a distance between the fracture, and it is very important to establish the segment. Otherwise, if you are not making that correct length discrepancy of the segment, you will have a problem with your grafts, vessel grafts, and it is very important to remake the bone continuity. At the crash site, you have to prevent the victim, avoid the spinal flexion. It is very important because in some cases you can have an undisplaced fracture, but if in your abnormal maneuvers for flexion or extension for the spine, you can transform that undisplaced fracture in a displaced fracture. And it is very important to make a longitudinal traction of the patient, never make flexion or extension for the spine. For the cardiopulmonary resuscitation, you have to make some maneuvers, and we will discuss about it. And you have to make a temporary hemostasis, avoid the tourniquet. The tourniquet is a band that we are using for hemostatic in our emergency room for stopping the bleeding. Transportation to a specialized department, it is very important to be very quick with that. You have to put the patient in lateral decubitus after the loss of consciousness. And it is very important to supine in fracture limbs. But you have to think about it, and you have to put a diagnosis about the fracture to make that maneuvers. It is very important to make a medical team quick, complete lesion review to have correct diagnosis and complete diagnosis, not just a diagnosis of fracture of in our patients. It is very important to have a complete lesions review. To determine the surgical indication depending on severity of injuries, and it is very important to make very quickly all our investigations and to know if it's an open fracture or a closed fracture. It is very important to establish that types of complications of fracture, because the treatment is different and the complications are most common in open fractures. That's a case of a patient with a traumatic injury, a car accident that has a complete fracture with the displaced of the hip. We have a hip dislocation. What's abnormal with our pelvic? Could anybody tell me what it is abnormal? Do you know the segments that we are seeing on that image, on that X-ray? What kind of X-ray is?
Anteroposterior.
That's an anteroposterior pelvic, an anteroposterior view. Okay, it's all right. Where is the fracture? We have a complete fracture on the acetabulum. Okay, and what's abnormal? What does it mean we have a complete dislocation?
That the head of the femurs is out of the.
Okay, very good. The femoral head, it is not more in contact with the acetabulum surface. Okay, we have here the neck. Here is the neck of the femur. Here is the head of the femur. Here is the acetabulum. For normal, in the normal view, we have the head of the femur in contact with the acetabulum. In that case, we have an abnormal position of the head. You can see the head is upper than the acetabulum and it is no more in contact. By putting a correct diagnosis, do you know how many incidents we have to ask for the X-ray? To have a complete view, to have a complete diagnosis, to see all the type of displacement of the fracture or of the dislocation. In that case, you cannot say, you can say just it's a superior dislocation, because you can see on the front view, on the anteroposterior view, you can see an abnormal position of the femoral head.
Should we ask for a lateral view?
Yes, it is very good, because in the lateral view, you can see it's an anterior dislocation or posterior dislocation. In that view, the front view, you can say just it's a superior dislocation, but you don't know if it's a superior and anterior or posterior dislocation. And it is very important to establish the correct type of dislocation and to name the dislocation, because we have to make some maneuvers for reduction, and we will not know how many types of maneuvers and what's the type of maneuver that we have to do to reestablish the continuity in our joint. And it is very important to have a correct and complete diagnosis. What is abnormal? More abnormalities on that X-ray. Do you see here? It's an what's that? Anatomically, that's the obturatory ring. Okay. We have 3 bones here. What's the name of that 3 bones that make the obturatory ring? Do you know? That's the ilion, ischion, and pubis. Okay, and here you can see it's a displaced fracture. We have in that case 2 types of lesions. We have a joint dislocation, okay, here, and we have a fracture here. Do you think we have some problems in the evolution in that type of fractures? What the most common or the most frequent complication in time in that cases, in cases of intra-articular fractures? Because you know, it is very important to establish the type of fracture, if it's an open or closed fracture, and it is very important. You have to determine that at the clinical examination, because on the X-ray you cannot see the soft tissues, and you cannot say if it's an open or closed fracture. You cannot say with it's complicated with an injury on the vessels or on the nerves. It is impossible to make that just on the X-ray. But you can say, you can see and you can say and told us what kind of fracture is. It's an intra-articular fracture or extra-articular fracture. What do you think?
Intra-articular.
Very good. It's an intra-articular fracture. Why it's an intra-articular fracture? Because we have a fracture on the acetabulum, and that area of the acetabulum has cartilage. When a fracture have some cartilage there, you will told us that it's an intra-articular fracture. And what kind of complication do you think it could appear in time in that patient?
Non-union?
No. No, for intra-articular fracture, it isn't the most common complication, the union. In shaft parts, in shaft areas, it is the most common complication, the ununion or malunion. But in our case of intra-articular fracture, we have another complication that could appear.
Thrombosis?
No. I've told you that we have lesions in the cartilage. What does it mean?
Infection.
No.
Osteoporosis?
We don't know. We don't know that it's an complicated fracture with a vessel, with a rupture of vessel. We don't know that. We just have an X-ray and we are looking at that X-ray. We don't have any more investigations in that case. Hip arthritis. Hip arthritis is the most common because you have a combination of two types of lesions. The first one, and it is very important, is an intra-articular fracture, that we have a fracture on the cartilage too. Okay, we have lesions on the cartilage here on the acetabulum area. Other problem in that type of lesion is there goes an important vessel that goes in our femoral head for nutrition. And you will have a problem with that vessel. And in most common, the complication for that type of lesion, it will be the hip osteoarthritis. Okay, can you say it's a polyfracturated patient? We have a fracture here and another fracture here and on the acetabulum and a dislocation. Can you say it's a polyfracturated patient? What do you think?
No.
Okay. The definition for the polyfracturation patients, it is that we have to associate 3 or more than 3 segments that have fracture. We have to have a fracture on the forearm, for example, of the ankle and of the femur. That's a polyfracturated patient. If you have a comminuted fracture or compound fracture, that means the comminuted fracture means more than 3 fragments of the bone, but in the site of the fracture. It doesn't mean do you have a polyfracturated fracture. But if you have a polyfracturated fracture patient, do you think it's a polytrauma patient?
Not necessarily.
Not necessary. It is very important to associate other lesions, okay, to be a polyfracturated patient. Okay. it is our case that have a dislocation of the hip, a fracture of the acetabulum, and a fracture of the what bone is that?
Tibia.
Tibia.
Tibia. Mhm. It's in the middle part of the shaft. Okay, do you have two segments? You can say it's a polyfracturated patient. Okay, what's the treatment for that type of middle part of the shaft of the tibia? What do you
Surgical.
think is that?
Surgical.
It is a surgical treatment, but it is very important to establish what kind of surgical treatment. And we have put that images for you to understand what kind of treatment we have to use. And the treatment, it is very important, it is correlated with the site of fracture. The tibia shaft, the middle part of the shaft of the tibia, it's an extra-articular fracture. And you can make a closed osteosynthesis and put a nail, a locking one. You have a screw proximal and a screw distal to the site of the fracture. You can put more than one screw to lock the fracture, to stabilize the fracture, because it will exist some rotational displacements if you are not making a locking nail. But it is a closed reduction and closed fixation of the fracture. It is from the distance of the fracture. In the shaft fractures, you can use that kind of treatment, the closed treatment, okay, and intramedullary nail. But in the case of the intraarticular fracture that we, like in that image, you can see a fracture on the acetabulum. It was made an open osteosynthesis. Why? Because you have to make an anatomical reduction to put the bone fragments in place and to rearrange that fragments anatomically. Why? Because of the complication in time is hip
Arthritis.
arthritis. Very good. Okay, we have different types of treatment, but it is very important if the fracture are complicated or not with other types of lesions. It is very important to have soft tissue lesions. It is very important to establish if the soft tissue are normal or not. It is very important to establish if we have an vessel damage. It is very important for the hemorrhagic shock. It is very important to establish if we have nerve injuries. In polytrauma patients, in polyfracturated patients, and in polytrauma patients, you have to think about all the types of complications, all the types of local complication or distance complications that other organs could be affected in our trauma. Other case of fracture. Can you tell me what it's that image? It is an X-ray of forearm. Do you agree with that?
Yes. Yes.
Okay. What kind of fracture is here? It's an extra-articular one or intra-articular one?
Extra.
Very good. It is a comminuted one or not? It is a simple fracture. It is comminuted. Okay.
Yeah.
Very good. We have a fragment bone here, other one here, here other fragments, small fragments. It's a comminuted one. Okay, it is displaced or undisplaced. And if you are telling me that it's a displaced fracture, you have to establish what kind of displacement.
Transversal displacement.
Yes. And most important, you have a big angulation. Do you agree with that? That's the normal axis, bone axis, and you have an abnormal bone axis. And it is very important to establish all the types of the displacement. Can you tell? Sorry?
Overlapping?
Overlapping, very good. It is very important to establish all the type of displacement. Can you tell me all the types of displacement in that image, from that image? I think not. You have to ask for other incidents. What kind of incidents? What kind of incidents we have in that image? Anteroposterior view. Do you agree with that?
Yeah.
Yeah. And we have to ask for supplementary incidents. We have to ask for a lateral view to make a correct diagnosis. Okay? What kind of treatment do you think that we have made in that case?
Surgery.
Surgery, very good. Do you think it's an open reduction or a closed reduction? Because we discussed the gold standard treatment for the closed fracture, and it is a closed fracture. You cannot say on that image, but I know the case. It is a closed fracture. And in that case that we have a closed fracture, shaft fracture in the middle part, we discussed that the gold standard treatment, it is represented by unclosed reduction. Do you think in that case we have made the closed reduction?
No.
No. That's an exception from our shaft fractures. Why? Because we have a rotational instability for the radius and ulna. When we are making the pronation and supination, we are making a rotation from our forearm, and in that kind of rotation, we are making on rotation on the bone fragments. And it is very important to reestablish the alignment of the bone and to lock all of the movements. And for that kind of fracture, we have to use two approaches, one for the ulna and other one for the radius, and to lock with that plate and screws. I have another question. Do you think it is a polyfracturated patient?
No, because there are no more than 3 segments.
Okay, could be more than 2 segments, but it is just one segment because we are talking about the fracture of the radius and the ulna, and it is on the segment. Okay, it isn't other segment, and it is very important when you have a segment with 2 bones. You cannot say it's a polyfracturated fractures patient. Okay, it is very important to establish that. But if our patient has that forearm fracture and the fracture on the acetabulum, it is a polyfracturated patient.
Yes.
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 Yes, very good. What do you see abnormal in that image? You have to look at all bone segments. It is a front view, a pelvic front view. What is abnormal?
It is a dislocation of the obturated bone.
No, dislocation appear just on the joints. Okay, we have dislocation for the joints or displacement for the fractures. We have here the head of the femoral head, and here is the acetabulum. They are in contact. You cannot say it's a dislocation if there exists a contact between the both joint surfaces. Okay?
Then it's a displacement, something like this.
Where? On the
At-
femoral head.
Yeah, and the acetabulum.
It is in an abnormal position. Do you think it is in an abnormal position?
Yes.
And I agree with that. What kind of abnormal position? It's superior? On the front view, you can tell me about the displacement, about the type of the displacement, if it's superior or inferior. Just that.
It's
Is
inferior.
superior or inferior?
Superior.
No. That's the superior wall of the acetabulum, and you can say you can see that it's on the acetabulum surface. It's not superior. That's the iliac bone, okay, and that's the most normal position, and that's the obturatory ring, okay. We have a fracture of the acetabulum, and the head goes from pelvic area, okay, because we have an acetabulum fracture with displacement. It is very good. You can see very good on our CT scan. You can see here the fracture. You can see here how the head goes from pelvic area, but it's not a joint dislocation. It's a displaced fracture of the acetabulum, and we have an abnormal position, but is in place the femoral head. What kind of complication do you think could appear in that kind of fracture, in that type of fracture?
Hemorrhage.
Could be.
Hip arthritis.
Hip arthritis the most common, but in time. Okay, very good, very good. Could appear hemorrhagic shock because there exists some important vessels here in the pelvic area, and it is very important to diagnose and to put a correct diagnosis if we have lesions of artery, of vessels, or nerves. Very, very good. Do you see something abnormal more than that acetabulum fracture?
In the vertebral column.
Now we cannot say anything about the spine because our incidence, it isn't correct, and we cannot see the spine very good. That's the sacrum bone. Okay, that's the sacrum, and from here goes the lumbar vertebra. Okay, you cannot see the spine on that incident.
Maybe the pubic tubercle. There's also
very good. The pubic symphysis. Okay, we have a fracture here on the obturatory ring. We have very big blood loss in that kind of fracture, and it is very important because our hemorrhage will go on the retroperitoneal space, and it is very important to see all the types of the lesions, because we have a fracture here on the acetabulum surface, that we have a bleeding here that goes in the retroperitoneal space, and other type of fracture here that goes in the retroperitoneal space. And it is very important to establish all the types of the abnormal signs of all the lesions. It is very important because you have a big hemorrhage in that kind of lesions. Okay, so what kind of treatment could apply in that type of fracture? What's that? What do you think is that? That's an reconstruction plate. That's an open reduction because we have an intra-articular fracture and we have made an open reduction and fixation with a reconstruction plate with screws, okay, to reestablish the surface, the acetabulum surface in place, to reestablish the joint and to make it anatomically, okay? Other case. What kind of images do you have here? The first one. What's that?
The femur inserting on the pelvis.
No.
Ilium fracture?
Yes, it's an ilium fracture, but more than that, you have to establish if it's in that image. You can say that it's with a little displaced or undisplaced fracture, but it isn't like this because you will have to check superior here on the iliac, sacroiliac joint. You can see it's in an abnormal position. We have a fracture here on the sacrum and a fracture here on the obturatory ring. And it's fracture, it is very important to establish that because it's unstable vertically, that kind of fracture, and we will have a big blood loss and could appear the shock, hemorrhagic shock in that case. It is a polyfracturated patient.
No.
Yes.
Why? Look a little here. You have an association of the pelvic fracture that goes here from the obturatory ring and goes here from the sacroiliac joint. And do you have something abnormal of the knee joint? Do you have a front view and a lateral view of the knee joint? Here we have the femur, femoral condyles, tibial plateau, and shaft of the tibia. And that's the peroneus and the head and neck of the peroneus. That's the patella. Okay, it is something abnormal with that image.
It is a bit displaced.
Where?
Tibial fracture right on the plateau.
Anytime when you are telling me that you have a displaced, you have to tell me where is the fracture, where is the displaced, where is the joint dislocation, how is the displaced. Tell me more about it, please.
Tibial fracture right between the shaft and the plateau.
Okay. Do you think it's an intra-articular fracture? Because it is very important for us to establish that it's an intra-articular or extra-articular fracture, because the treatment is different for intra-articular fracture and extra-articular fracture. And complications and evolution of our patient, it is different between intra-articular fracture and extra-articular fracture. In extra-articular fracture, you don't have to use an anatomical reduction. You can make a closed reduction without any incision on the fracture side, but in intra-articular fracture, you have to make an anatomical reduction reduction. We are naming the anatomical reduction a step no more in the cartilage, a step no more than 2 millimeters. That means very hard. What's your opinion about that? It's in an intra-articular fracture or extra-articular one?
Intra-articular.
Very good. On the medial part of the plateau or external? What's your opinion? In my opinion,
The medial.
it's the external one. And how do I know if it's internal that and external that part of plateau? How can I name? How can I establish that's the medial plateau and that's the lateral plateau? How could I?
Looking at the fibula.
Very good. Very, very good answer. Yes, that's the correct answer. We are looking at the fibula, and for normal, in all patients, the fibula has to be in the lateral part of the tibia. And if you are looking for the fibula head, you will know that the fibula head is on the lateral part of the plateau. Very good. And we have in that image an intra-articular fracture of the plateau in the lateral part with displacement. Do you think it's with displacement or not? In my opinion, it's with displacement. But you have to tell me why it's with displacement. How can you establish that displacement on the front view of the X-ray? The first one. If you are making the normal axis, the normal biomechanical axis goes from the center of the shaft of the femur and goes the center of the shaft of the tibia. Goes from the center head of the femur, goes in the center of the knee, and then the center of the ankle. In that image, you can see it's an abnormal inclination of our plateau. Can you see that?
Yes.
That means it's with displaced. If you are looking at that image, you can say it's with a small displacement or undisplaced, but it is incorrect, and you have to correct the biomechanical axis. Otherwise, you will have a big complication with that patient. What kind of complication?
Secondary displacement.
No, because it is with displaced. If you are not established the anatomically position, the normal position could not appear secondary displaced. Secondary displaced appear just in case of good reduction but poor reduction with poor osteosynthesis, and it will goes to secondary displaced. Now, it will develop knee arthritis. Okay? And you will have to reestablish all the steps in your cartilage. And it is very important to reestablish the biomechanical axis for a good evolution. But our patient has a trauma on the head, a cerebral trauma, and a trauma of the spine. Do you think it is an polyfracturated patient?
Yes.
Yes. Do you think it's a polytrauma patient?
Yes.
Yes, very good. Because we have a blood loss here, we have an injury of the head, and it is very important, and we have a fracture of the spine. It is very important to establish all the diagnosis. You can see it's a displaced fracture, and we'll have to make osteosynthesis on the spine too. Okay, it is very important to establish all the diagnosis. That's the correct treatment. Okay, in that case of the fractured spine, you will have to make an osteosynthesis with special materials of osteosynthesis. That's the neurochirurgical specialty. We are not using anymore the stabilization of the spine. We are making the stabilization, and we are treating the fracture of the pelvic ring, acetabulum, and the knee, and at the spine we will speak with a neurochirurgical specialist. For example, head trauma have to diagnose by CT scan or MRI. It is very important to check in all the cases with a CT or an MRI to put a correct diagnosis of the trauma. If you have some questions, please.
Can you just explain really quick the open reduction versus the closed reduction?
Okay. It is very important to have a correct diagnosis about the fracture and to know the type of fracture. The best treatment in all the fracture is the closed reduction. Closed reduction, that means you don't have to make any incision. You are making some maneuvers with the skin intact, and you have to make some maneuvers with an RX TV in our operating room. We have an TV that we are making that reduction and then make the fixation. For example, for that type of tibia fracture, sorry, okay, that's the slide. You are making some maneuvers, but without any incision on the fracture side, and you have to make some maneuvers to reduce the fracture, and then your incision will be in the distance, on the fracture side, because you are making an incision on the knee, inferior to the patella, and we are introducing from superior to inferior the wire, our osteosynthesis material, and we are not opening the fracture. We have some advantages in that case. What do you think? What advantages do you think we have in the case of closed reduction and closed fixation?
More sterile environment.
Okay, very good. The contamination. Do you mean the contamination?
Yeah.
Yes, very good. It's a higher contamination in open reduction. Very good. About the blood loss. It is smaller or bigger in close reduction? It is smaller.
Smaller.
The hematoma. The hematoma had some special substances that are very good for the healing of the fracture site. And it is very important to maintain the hematoma of the fracture bone. And with that substance, we have a higher advantage for a good evolution in healing for the callus. Okay? But
Muscle trauma.
excuse me?
Muscle trauma in surgery.
Muscle trauma. Yes, do you have some muscle trauma? fracture, it is impossible to make a close reduction because our reduction has to be anatomically. It isn't allowed to have a step more than 2 millimeters in our cartilage, because otherwise we will have for sure the complications of arthritis. And it is very important to make an anatomically reduction. Okay, that's the difference between the closed and open reduction. But if you have a high injury, like in that case of patients with a higher energy trauma, a big trauma, it could be a patient with soft tissue damage. And it is very important to put a correct diagnosis about the soft tissue. Like in that image, you can see it is a wound there, it is an open fracture. In that case, you cannot make a close reduction because it is open from the accident. But you cannot make an open reduction and a normal fixation with the plate. Why do you think we cannot make that? Because of the contamination. At the accident site, it is not a sterile place, and it is very important where is the wound made. Okay, if you are making an incision in the operating room, it is a big difference when the patient have an incision or a wound post-traumatically on the car accident. Okay, it is a big difference between that types of wounds, and that's an abnormal osteosynthesis that we are making. You can put that kind of osteosynthesis, and you can make that kind of osteosynthesis sequentially. You can use an external fixation like in that image, and if you have a good evolution on the wound, in 4 to 6 weeks you can put it out and to make a normal osteosynthesis with an intramedullary nail, for example, because we have a poor fixation of the fracture site with that type of osteosynthesis material, with the external fixation. But the evolution of the wound, it is very important, because you don't touch with that osteosynthesis, with that material, you don't touch the fracture site. It is from distance to the fracture site. And that's very important. That's the treatment that we are using in all the cases with big wounds, with complications, with polyfracturated or polytrauma patients in emergency. And then if you have, after putting that osteosynthesis material and antibiotherapy, and if you have a good evolution on the wound, you can make the final treatment after with, for example, in that case of intramedullary nail. It is clear?
Yes, thank you.
With pleasure. Other questions? Okay. Thank you.
Thank you.
Thank
Thank
you.
you.
Doctor.
Thank you.
Thank
Have
you.
a nice day. Bye.
Thank you.
Pleasure. Și studenții sunt cei mai slabi, englezii sunt cei mai slabi. Și pe mine m-a uimit cu întrebările.
Deci, întrebări, răspunsuri, implicare, au salutat